Without further ado, Dr. Clore.
Thank you so much, Dr. Houston. I can't talk and do technology at the same time, so bear with me. All right. I am assuming everyone can see my slides now.
Yep, we're good to go.
All right. Thank you. All right. So I have no financial or non-financial disclosures to share. I do jokingly add that I have one disclosure, which is that what I'm about to teach you might improve your interpersonal relationships in your life beyond those just with your patients. So some generalization tends to occur with these techniques that you're about to learn. So they're not just for patients, but you might find themselves using them in your private lives as well. I'm hoping to help you learn some early warning signs and characteristics of your challenging patients, describe how empathy, compassion, and validation might improve your interpersonal conflicts, and describe some implementation and application of these new strategies. And overall, I think there's a secondary effect of using these skills that will help you then improve your own resiliency because you'll feel more effective in your professional role. So, who are your most difficult patients? Um, if you guys can open your chat and throw some things in the chat, or you're welcome to unmute your mic and shout out. But I know sometimes people are a little more shy about that. But if you want to just throw into the chat, like what are some descriptions of things that you find difficult about some of your patients, or what characteristics would you use to describe kind of those that you label challenging or difficult patients? Combined developmental disorder and personality disorder. They don't want to be there. Patients with difficult views on other human beings. That's a really good one. Patients expecting to get what they want. Yeah, good. Thank you, Dr. Weiss. So here, this is really consistent with a lot of the things that I hear when I give this talk in other settings. People who are disrespectful or manipulative or demanding, sometimes drug seeking or hostile. So, all sorts of different characteristics kind of come to mind. And we kind of ask ourselves, like, why is it difficult to work with these people? We're supposed to be empathetic, providers. Like, what's the problem? And I just like to kind of normalize it for a moment to say, beyond knowing kind of what tests, differentials, and medications you might be thinking about during this patient encounter that you're doing. So all the like science stuff that you're required to know. You're also required to listen and build rapport and show empathy. Oh, and please do it as quickly as possible while also managing your electronic medical records. There's a lot going on in any patient encounter. It's hard enough when our patients are these nice, lovely grandmother type, persons. And it's completely different when we have these challenging or difficult patients that are more demanding of our time and acting, belligerent or hostile towards us. So just kind of normalizing that these are, our patient encounters are difficult under the best circumstances because there's so much to juggle while we're engaged with our patients. And then adding this extra layer of a challenging patient just can be enough to just kind of divert the whole thing. So I want to share with you three tips that make it easier. One is to understand why people behave the way they do. As Dr. Houston shared, I did my schooling at Western Michigan University, which is known for its behavioral approach to psychology. And I think understanding human behavior is super helpful in understanding and kind of taking a step back from the encounter so that you're not necessarily taking their behaviors personally. Second is to validate their emotional responses and urgency because that can de-escalate things. And then to remain mindful of a few basic tenets of human behavior. So these are the three things I'm going to go through with you today. The things that I'm sharing come from a variety of different places in my training, my behavioral background, my expertise in dialectical behavior therapy, and then also a secular course in compassionate mindfulness developed by Emory University that I was trained in called cognitively based compassion training. So, kind of pulling in things from all of these different resources to share with you today. So, first, understanding why people behave this way. So, of course, as a psychologist, I'm going to ask us that we all do some self reflection as we get started. If you have something to write on, that's great. If you just want to do this kind of mentally in your head, that's fine too. But I want you to think about a time when you last behaved in a way that you were less than proud of. So, sometime in the past week, maybe longer for some of you who, are always on your best behavior. But think about a time in the last week where, okay, maybe I could have handled that better, or maybe that, wasn't my best moment. I promise I won't be asking any of you to self-disclose or, share publicly. So this is just for yourself. So think about what contributed to it or what gave rise to it. Like, what was the circumstance that gave rise to you behaving that way? What kinds of thoughts were you experiencing at the time, either about the situation or about something else or yourself? What emotions did you experience at the time? How did you appear physically to other people? And then I want you to push yourself and think about, okay, was there something else that may have contributed to it? We often think about the situation that was in the immediate proximity to the behavior, but was there other things that happened earlier in the day that might have primed you to behave that way or contributed to you in some way? So I won't make you share an example, but I think examples are helpful to work through as we think about these things. So I will put myself on the stage here. I have identical twin 15-year-old boys who have been playing soccer for over a decade. And for reasons unexplained to me, and they lose their shin guards all the time. Even now, even though we've been packing soccer bags for over a decade. And so there are many times that I come in and the kids don't have their stuff, and I just roll with it. I practice my radical acceptance. I kind of see it coming. I prompt them. I do all these things, and we eventually get to practice or to the games. But occasionally I lose my cool. And I had recently told the boys, I'm coming in hot from work. We won't have much time. I'm basically going to pull in the driveway and you got to jump in the car if we're going to get there on time. And of course, this occurred, but they got in the car and they're like, oh, but we can't find our shin guards. So I lost it and yelled at them. So what contributed to it was their lack of responsibility that I perceived. I had thoughts like, I've told them 1,000 times to just put their shin guards in their soccer bags. Like, why they're anywhere else, I don't know. And so they still, seem to leave them in the mud room or in the bathroom or in their bedroom, all over the place. I was feeling frustrated and angry because I like to be on time. I was physically tense. I was talking loudly. My kids would probably say I was yelling at them. And when I think about, okay, what was different that day? Because this happens a lot in my life. Why did I lose my cool that day? And I didn't, earlier in the week or another time. And I think about, okay, well, what was different about that day? Well, I was also in a faculty meeting that day where I felt disrespected from a colleague of mine. And so I was in some ways kind of primed or like, kind of ready to feel, disrespected or kind of put off. And so that was kind of lingering in the background when this occurred. So going back to your example, now that you've heard mine, kind of flesh yours out a little bit. If you're writing it down, great. If you're just thinking it in your head, just kind of be like, okay, what was it that I was thinking and feeling? And is there something that kind of in the background really contributed to it or primed you to behave badly? And I just want you to keep this example in mind as we walk through today's topic. So going back to our patients, they're, having problems with all these different characteristics that we find difficult. Now I'd like you to open the chat and talk to me a little bit about why people behave this way. So our patients are, perhaps being disrespectful to us, or they have expectations not being met, they're demanding. Why do people behave these ways? Like, oftentimes our patients are kind of on their best behavior when they go to see a doctor, but that doesn't always occur. And so, why is it that some of us are, feeling they're challenging? They're feeling unheard, good, because they may have been the only, it may have been the only way to get their needs met in the past. Great. Any others? Emotional dysregulation and poor distress tolerance. Oh, that's from one of my residents. So smart. Thank you. And she hasn't even been in DBT yet. That's how they thought their parents get their way. Great. Okay. All good stuff. So yeah, we, frequently in DBT refer to these as kind of vulnerability factors. And so, having a bad day or stress, maybe they're fearful or anxious. Maybe they have some unmet needs. Maybe they have some traumatic experiences that we're unaware of. Oftentimes, when I catch myself behaving badly, I pay attention to how I'm feeling physically, and then I clue in and be like, oh, right, I forgot that I woke up with a migraine today and it's still like lingering, or I have some sort of headache, or sometimes I'm just really hangry because I don't do well when I skip meals. And so, lack of sleep, unmet expectations, like was mentioned, not feeling respected, like I was in my example. Sometimes there's just a skills deficit, right? Like they don't have the interpersonal skills necessary to navigate this in a way that's more effective. So, all these things that make our patients vulnerable are very similar and all the same with things that make us vulnerable to behaving badly as well. And all of these things impact our interpretation of any given situation, and they alter our lens and what we're seeing the situation through. So I shared with you, like, this situation of losing the shin guards happens all the time. Why is it that some days I can manage it really effectively and other times I, fly off the handle at my kids? And I think it all depends on what's going on in the background and these vulnerability factors and how that alters my lens on that particular day. So think about what your lens is. I want you to imagine that you pull in your driveway at the end of the day and your neighbor comes up to you and says, hey, Doc, I got this really complicated case I'd like you to see. He's a friend of mine and just the nicest person, but what's your initial reaction to that? You don't have to put this one in the chat, just think about it. If you're having a really bad day, you might think, oh, geez, here we go again. How can I get out of this? Like, what's the fastest way I can get into my house and not talk to this neighbor? If you've recently had a bad review or evaluation, you might think, oh, I can't even help this person. Like if it's a complicated case, I'm not the person to do it. Or you might be having a great day where you knocked it out of the ballpark with all your patient encounters, and you might be very confident and say, I love a challenge. How can I help? And you might spend the next 30 minutes talking to your neighbor about this person that they want to refer to you. So it really just depends on kind of your lens and what's happening. All of these are valid responses, but they're also going to lead to different behavioral responses, right? So our patients are no different, except that their lens is going to be a little bit more distorted, which is going to lead to more distorted behaviors. And it's going to be slightly more distorted because of their disorders. So I want you to imagine a new patient that comes in. This is a 73-year-old male. He's been rude to the nurse. He complains about your being late as soon as you walk in. He didn't bring his list of medications. He doesn't know his current meds. He doesn't know why he's been referred to you. He doesn't like new doctors, and he demands immediate pain relief. What's your initial reaction to this patient? Again, this is rhetorical. You can just think about it. I want you to then think about, does your lens change if you learn that this patient has been diagnosed with a neurocognitive disorder? You probably wouldn't say to him, you really shouldn't be so forgetful, right? Similarly, if they were diagnosed with a thyroid problem, you probably wouldn't, tell them that they need to change their moodiness. Similarly, we go to psychotic disorders. You're not going to say, don't be so paranoid. I'm a great new doctor. I'm going to be fine. Or if they're a substance use disordered patient, you're not going to say you really should try to get your agitation under control. But yet you can see as we work through this list, perhaps by the point we get to substance use disorder or personality disorder, some of you may have had this inclination to say, well, but there's a little bit more control over those behaviors in those disorders. And so maybe, we would say these things. At least I will say that I have heard on our inpatient units things to people with personality disorders like, you should be less manipulative or don't be so demanding. Like I have heard those sorts of things, shared with personality disordered patients. And I'd like to make the case for why the symptom responsibility when our disorders are seemingly more neurological versus interpersonal shift, and that it shouldn't necessarily be that way. So, it always sounds ridiculous if you said to someone with a psychotic disorder to, stop hallucinating, because obviously that's not something in your control. I would argue that telling someone with borderline personality disorder to stop being so manipulative is kind of similarly ridiculous. So we know from several studies now that there are biological influences for people with personality disorders, particularly cluster B. There's evidence that there's a smaller amygdala that is then overactive. There's this continuous hippocampus hyperarousal that's misinterpreting threats and is basically then sending fake news to the amygdala. They also have higher levels of cortisol, so they're feeling more overwhelmed more consistently, and less active prefrontal cortexes. So much more impulsivity and being ruled by their emotions without that frontal cortex to come on and kind of rationalize and say, hey, let's, think this through. And that is in combination with environmental influences of validating caregivers, possible trauma, and modeling intolerance of emotional dysregulation. So I would argue that symptom responsibility shouldn't shift depending on our diagnosis, but rather, even though the symptoms of personality disorders are interpersonal by nature, we recognize that there is a biological and environmental background for all of these symptoms, no different than folks with bipolar disorder or psychotic disorders and their symptoms as well. So it's important to keep in mind that our personality disordered patients or our challenging patients behave badly for the same reasons we do, but also because of their disorder that is going to make it even more distorted in their lens. And understanding the etiology of personality disorders, the biological, the genetic, environmental, and cognitive influence can help us shift the blame off the patient, and which is going to open the door for more empathy and compassion when working with these patients. Because as I always tell our residents, as soon as you get into an argument with someone with a personality disorder, you've already lost. So I think kind of sitting back and recognizing what's going on in the background for our patients can open the door to proceeding in a more empathetic and compassionate way. So second, learning to validate emotional responses and urges. Lots of talk these days about validation. And it's my world mission or life mission to make sure everyone knows what they're talking about when they throw the word validation around. So I think you probably are all familiar with reasons to validate. It de-escalates emotional intensity. It communicates that you're listening and caring and understanding. And it reduces the pressure in our patients to prove themselves right. Oftentimes because you're kind of agreeing with them and they can like let go of the argument. And it facilitates problem solving and support because you're not getting caught up in the argument about the reality of the situation or of the feelings they're having. So going back to your recent time that you lost your cool, maybe you chewed out a colleague or you forgot important documentation or you misdiagnosed a patient or something. Mine was that I yelled at my kids. I want you to think about how did your brain respond to that? When you were thinking about your own bad behavior, per se, was it uncomfortable for you? Did you beat yourself up? Or are you someone who rationalizes? I could say to myself, oh gosh, I'm such an awful mother. I can't believe I yelled at my kids. I know that's not effective parenting. Or I could rationalize my behavior and be like, you know what, those jerks totally deserved it. They were mouthy and they, don't seem to think that this is a big deal, that they don't know where their shin guards are. Or do you acknowledge the situation, accept the reality and the responsibility for the behavior, do some self-soothing and lessen your distress? Because this is self-validation and what you want to provide for others. And so I'm going to kind of walk through how to do that. So keeping in mind that validation is communicating that a person's response to a situation makes sense. It is taking people seriously rather than discounting or minimalizing them. and searching for and recognizing and reflecting the validity inherent in their response to the events that occurred. So this is not approval of unhealthy or ineffective behaviors. Um, I don't want to, the response, if I confide in a friend about this, I don't want their response to be, oh, yeah, I yell at my kids all the time. It's totally okay, right? Because that's not okay. And it's not consistent with my values and the parent that I want to be, but rather acknowledge that the feelings and the urge to behave in that way made sense given the situation. So the things that you can validate when you're not trying to say that, yeah, this behavior was the right thing to do, you can validate the feelings and emotions that went into it. Like, I can see you're really upset with me because that part is valid. You can validate the legitimacy in wanting something. For patients coming in and wanting, immediate pain relief, you might say, I know you want your pain to go away forever, and right now I don't have a magic wand. So you're validating that desire for whatever it is that they want. You can also validate their beliefs, opinions, or values, whether or not you agree with them or not. So going back to Dr. Houston's comment about difficult patients that have, like challenging views of other humans that were difficult for us. I think that is a really difficult thing because you don't want to necessarily validate that view or that value, but you can validate that it's theirs, right? You can say, I can see that's really important to you, without, saying that it's one of your own shared opinions or beliefs. Um, and you can validate how difficult things are. So it's really hard to get out of bed when you're so depressed, like validating that, our patients, when they're saying, I can't, I just can't, I just can't, you can validate, yeah, this is really hard. And also the attempts that they are making. And so any little steps that you see towards improvement, you can validate and say, like, I know that you're trying the best that you can right now. I know that showering once a week is the best that you can do right now. And that's, okay. So, recognizing that those and validating those efforts that are being put forth. Some steps, this is very basic, you know, interpersonal skills that many of you already have, but just kind of keeping them in mind when we think about validating. Make sure you're paying attention, right? You're actively listening, and you're doing so without judgment, and you're responding non-verbally so that you're communicating to the patient that you're listening. And you actively want to try to understand the worldview, like, really figure out what it would be like to walk through the world, if you were that person. Second is reflecting back. Again, without judgment, feel a little bit of whatever emotions they're feeling and then let yourself show it. We can validate that a person feels threatened without agreeing that they're actually being threatened, or that a person is angry without agreeing about what they're angry about. So I use this a lot in my forensic work, actually, because that's where I encounter more psychotic patients that might be delusional and they're not taking meds and they're very fearful. And I can validate and I can sit with them and say, yeah, it must be scary to think that, all the food here is being poisoned, or to feel like you're being watched all the time. So you can validate that without necessarily saying, yeah, that's reality. So you can kind of let yourself show a little bit of that. With my other patients, like for therapy, if they're complaining or talking about like difficult relationships with parents or that sort of thing, and I feel like they have been mistreated by a caregiver, I will show that too. And I will even say things like, you know what, I'm really mad at your dad right now for this, because I agree that was an awful way for him to respond to that situation. So kind of letting yourself reflect back, not just, in your words and using, reflective statements, but like show the emotion yourself can be very validating to your patients. Like, oh, they get me. The third step, we want to go a step further and do a little bit of mind reading. And this is also known as being interpersonally sensitive. So you're trying to figure out, okay, what else might be going on that isn't being said? So are there some additional responses that you might have had in this situation? Or what can you observe in their voice, tone, or body language that was going on? Maybe they're just, kind of stuck on, oh, I was so angry. I was so angry. And you might be able to step back and say, if that were me, I might also be really frustrated or hurt in that situation, and just kind of throw it out there as a hypothesis. Some examples are, I can see that you're really excited about this idea, or I'm sorry, this isn't news you wanted to hear, it's probably pretty overwhelming. So you're kind of also guessing that they're feeling overwhelmed. Or you must be wondering why we changed the schedule on you. So the caution here is to tread lightly, and you want to be open to correction. You really want to throw these things out as possible hypotheses. You don't want to ascribe emotions to your patients and tell them how they're feeling, obviously, but rather just saying, like if I were in that situation, I think I would also be feeling this. Did any of that come up for you? And it's really just kind of helping their kind of processing of the situation. So it's not just, oh, I was just so angry, and they're kind of stuck on that. Um, and then start to understand the causes. So going back to the first step I shared with you, kind of understanding, okay, why did they behave this way? Take perspective, ask some clarifying questions. Be careful not to disagree, criticize, or attempt to change anything. This is not problem solving. That comes much later. This is just validating. So look for how their feelings, thoughts, and actions make sense given their history. So for example, it makes sense you'd be afraid to go out at night given what happened to you. Or it makes sense that you're feeling hopeless about this diet plan when all the other ones heretofore have failed. So kind of understanding their behavior in their learning history and context, and validating like, yeah, that makes sense that you would, do that or have the urge to do that or feel that way because this is what, has been your experience historically. And then you want to kind of bring it into the here and now and acknowledge the valid and respond in the current situation. So showing that um, and then in the current situation, it might be, it makes sense that you were yelling at them because you've had to go through this so many them to be prepared and they wouldn't. And so behaving in a way that that person's concern is valid is also really important. So I give the example of if I comes in and he's upset because I hadn't taken the garbage out, he might yell at me and say, it's your day to take the garbage out. I can't believe I have to go do it, and be upset with me. That's not the best time to say, you're just upset with me because you had a bad day, but rather just say, oh, right, it is my day to take the garbage out, and go take the garbage out. So you're just behaving in a way that is responding to the validity of their emotion. I might have a conversation with him later about how I didn't really appreciate the tone he used when he, yelled at me about whose day it was to take the garbage out. But the part that I'm paying attention to is that he has a valid feeling going on, and I'll address kind of how he communicated it with me later. But I'm going to respond by just going and taking the garbage out, as opposed to getting into an argument. So we similarly want to do that with our patients and not really argue about, okay, cutting wasn't the best thing to do, but rather say, I understand that urge to cut given that really difficult situation you were in. And lastly, you want to show equality. So treat the patient as an equal, not as frail or incompetent or less than, and practice willingness and acceptance, even if you don't approve of the behavior. Be willing to admit mistakes and apologize for them, even on behalf of the coworkers or organization. And an example I like to share on this one is early in supervising our dialectical behavior therapy clinic, I was running a group, and one of our patients who I was pretty familiar with came in, and I was really focused on teaching how to handle situations when patients came in without their homework completed. And I paid more attention to modeling that for the residents that I was teaching than I paid attention to the state of that patient in that moment. And had I been more attuned to the patient, I would recognize that she wasn't really in a place to receive feedback right then about, or to problem solve about how to get her homework done for next time. And so she ended up storming out of there and, told the front desk she was dropping out of DBT and, stormed off. And the next time she showed up for a med management appointment, I asked her if I could talk with her for a few minutes before she saw her prescriber. And she was a little bit nervous, but she agreed. And she came into my office and I just apologized. And I basically explained to her what I just explained to you, that this was what was going on for me. And I'm really sorry that I, kind of overstepped, and I should have paid more attention to kind of like what was going on in her life that contributed to not being able to do her homework on that day. And she immediately just changed her tune with me completely. She got back into DBT. She was like, "Oh my gosh, I thought I was in trouble when you called me in here." She's like, "I've never had a doctor apologize to me before. This is a new experience." So I think it's really important to show equality with our patients rather than kind of being in a us then kind of relationship. And just recognize we're all human and we all make mistakes. And sometimes I'll do this on behalf of the organization. I know patients or residents have asked me, like, what do you do when patients are complaining about kind of rules on the inpatient unit that you don't think are great rules either? And I think, you don't want to get into, reinforcing their splitting with them and talking about, oh yeah, these rules are so, stupid or whatever. You don't want to throw your organization under the bus. But I think it is okay to step back and say things like, a lot of these larger organizations have rules and regulations that I don't always agree with either. But what we have to do is figure out how to make them work for us, right? So you can step back and apologize or acknowledge the flaws in our systems on behalf of our coworkers or the organization and yourself. And I think that can really go a long way in kind of showing equality with our patients and recognizing, yeah, we're all human and make mistakes. So quickly going back to self-validation, thinking back to your less than proud moment example, the situation that gave rise to it, what you were thinking and feeling at the time, the other factors that were at play. Why did your behavior make sense? Why was it valid? So again, if you're writing things down, you might write a little self-validation statement, or just think about it in your head. That might be your new mantra for the week. And think about, how does your brain respond now? Are you being a little kinder to yourself? Are you maybe not rationalizing your behavior as much, but rather taking ownership and just kind of saying, yeah, that wasn't my best moment, but it makes sense that I did that. So for me, mine would be, it makes sense that I'd yell at my kids when previous attempts to hurry them along haven't worked. This is an actual photo of my kids when we're running late. All right, so validation. Validating your patient's emotions and associated urges will help de-escalate their intense emotions, communicate your desire to help, and pave the way to change. It's a lot less frustrating than getting defensive or arguing with them. So just take the garbage out. All right, my last segment here is on being mindful of a few basic tenets of human behavior. So this really comes from the cognitive-based compassion training course from Emory. So keeping in mind some basic human behaviors and tenets of them, that people are doing the best they can. So all people at any given point are doing the best that they can, and given the causes of behavior that have occurred up until this moment. So for example, all of you are listening as intently and going through the examples with yourself the best that you can right now, given that it's 7:00 on a Thursday after what's probably been a pretty long week. Maybe you guys haven't had dinner yet. You might be hangry yourselves. Similarly, I'm doing the best in this presentation that I can. Also, given that it's 7:00 on a Thursday, and that I have some distracting noises in the room behind me. So all of us are doing the best that we can in any given moment, given the context in which it's occurring. In addition to that, we want to do better. There wouldn't be the self-help books and sections in the bookstores that there are if people didn't want to improve and do better. So, common humanity tells us that everyone wants to increase happiness and decrease pain and suffering. This is true for every being. So, find your commonalities here and cultivate some impartiality. I frequently tell my residents, if you see a patient that you kind of know is challenging or difficult or anticipate them to be on your panel that day, in your chart review, think about, what do I have in common with this person? Are we both Cubs fans? Are we, from similar sized towns growing up? Do we have an interest in the same sports team or, same video game or what have you? So try to find some commonality that you have. If you can't come up with anything in common with this person, you could always fall back on your common humanity, and that is that you both want to increase happiness and decrease suffering, because that is, common characteristic of all of us. So if nothing else, you can always fall back on that. But I think when you have that impartiality cultivated before you walk into your patient encounter, you're going to start at a place of empathy and compassion, as opposed to, oh gosh, I have to see, Mr. Jones today. He really was difficult last time. This isn't going to go well, because then you're going to go into that patient encounter, and sure enough, it's not going to go well. So trying to find some common ground before you see these patients can be helpful too. Always keeping in mind that there is a cause or set of causes for actions, thoughts, emotions, even if we're not readily aware of them. So, our patients will say, oh, I went from 0 to 60, and there was, rhyme or reason to it. But if you really slow it down and look at it, there usually are some causes or set of causes for why things happen the way they did. This is my behaviorism, speaking out, but, when we really do start to dissect people's behaviors, it's pretty clear, what kind of causes or things factored into why things unfolded the way they are. So kind of remember that, okay, our patients are behaving this way for a reason, and it isn't about us. Judging and blaming is a lot easier, but it doesn't promote change. Understanding and changing the causes of behavior will. So keeping in mind we're all doing the best we can, we all want to do better. All behavior is cause, and understanding those causes of behavior is going to lead to more change than just judging and blaming. So if you find yourself feeling overwhelmed or dreading your next patient, or your empathy tank running low, remind yourself to think about why your patients are behaving this way. Validate their emotions and urges along with your own, and keep some common humanity in mind. If you do these things, you'll be a more effective physician. You'll be less burnt out by challenging personality disorder patients. You'll have more work satisfaction, and you might be a better human if you use this in your personal life too. So I will say thank you. And I will also share with you that my sons have become acutely aware of these techniques. And one of them is currently in AP Psych, which, is really testing my knowledge and patience with it at home. But my boys have become so good at this that now if I come home and I start, in on them about not knowing where their shin guards are, yell at them for something else. Frequently, one of them will say, Mom, did you have a rough day at work today? And of course, then I just melt and I'm like, oh, here's my lovely adolescent son who's like suddenly so concerned about how my day went, and I'm not longer angry at him at all. So be careful when your kids start using these tricks back on you. It's a lovely thing, but, you know, so that's what I have to share with you today. I am open to all sorts of questions if you have any, or difficult patient situations that you might want to present and ask how I might handle them.
All right. Thank you so much, Dr. Clore. So yes, questions, if you have them, feel free to raise your hand in Zoom or pop them into the chat. While we're waiting for some people to put their questions in, we do have one that was from like the registration form before the session. It's a little bit more